So this next session, and I'll just set it up, hopefully not, won't speak out of turn, has been a very, is the culmination of a very interesting journey for our organization. And it's culminated in where we actually started, both physically, first patients, organizationally, our first customer, and very relevant from both a scope and scale perspective. Involves the acute care settings of the hospital, community partners, GPs, specialized medicine, the nursing side, basically the full aspect therapies. And for us from a technology perspective, is become kind of the beachhead for us as we unpack and mature our organization around a structure that is essentially duplicated in every Western medical environment. So if you go to LHIN Health Sciences Centre in London, Ontario, and you show up in France or you show up in Detroit, you may see different patient demographics, but you usually see a structured national level hospital system like you'll see in LHSC. From a bells and whistles and the boxes you can check, do they have this, do they have that? So for us in working with LHSC, it's been a huge learning opportunity. And we've also had the ability to have a huge impact for the patient population, which is of course what ultimately drives our success, is positive outcomes. So without further ado, I'm going to introduce Laurie Gould, who's an SVP in Innovation, Chief Clinical Officer, just about everything. Transformation, who we've had the benefit of, what, almost 3 years now? Yeah. 3 years of working with each other. And Laurie's going to walk you through the CC2H project and introduce some other participants.
So thank you, everybody. It's my great pleasure to be here today to talk to you about this. Mainly because it's near and dear to my heart. When we started in this journey, I thought, okay, it was a prayer and a whim that we were going to make a difference, and I'd like to show you the difference it makes. But before we do that, I want to talk about some of my partners and colleagues that I've worked with. So Donna, at the time, was Vice President of the CCAC, which is our, in Ontario, the home care branch, and community care. So we worked with Donna very closely. This is Doug, who is a patient of ours. At the end of the day, this is all about patients, and this is why we're here. And it was important to have the patient's voice as part of both our planning and our development, but also what we ended up with and what a difference it's made. So we'll be looking forward for you asking questions to Doug. And then David, who's been working with us in a partnership. So I'm going to quickly walk you, well, or maybe not so quickly, I get a little impassioned about this, so hopefully respectful of time. How we started and why, and where we ended up, and then the outcomes that we've actually achieved to date, and how we're going to start to spread it. So would like to go. If you have any questions, burning questions, put your hand up. If not, I'm just going to assume that we'll go right after. So a little bit about London Health Sciences Centre. We're about, right now, 1,000 beds, plus or minus. We go up and down, depending on flu season and surge. We serve a large region, so our catchment area is about 1.5 million people. We are an academic health science center, but this isn't about healthcare. This is actually about how we care. I've often said we talk about a healthcare system. I want to talk about a system for health. And that's where I think as a system, we have to start going and saying, how do we partner together so that we can make a difference to our patients and also make a sustainable healthcare system. So there's probably one person on that poll that wrote sustainable, and that was me. Because I think if we don't do something very different and we don't leverage technology and wrap around teams of services to people, the healthcare system, at least in Canada, is not sustainable. The other thing, just for our London folks, I always like to call us Little London. So when I'm talking about London, it's Little London that we're talking about, not the big London, but still a very large organization. So why are we doing this? There was actually a case for change, and it started out of the acute care sectors. So how many people here are actually part of a healthcare system that has hospitals in it or is part of the acute care? Not too many, just a few. Right now, hospitals are feeling the pressure. You can read anywhere in Toronto, in London, in Vancouver, in Calgary, probably all around the world, about how our emergency departments are full of patients, how we don't have enough beds, how the volumes are growing, we don't have enough staff, and that was no difference where we are. So we started this program looking at what we need to change. And here was some of the data that were really driving this, and we were really starting to feel it, particularly in our region. So the first one is we're expected to see the tsunami of the gray. We've already heard about that. That's no big surprise. In our region, the number of centenarians are going to triple. So that's coming at us fairly quickly. And in addition to that, the age 85 and older is going to quadruple. So we don't have the capacity in hospitals, and I'm going to be the first one to say, I think hospitals are dangerous places, and you should only be in a hospital if you absolutely need to be in there. And that was one of the principles that we used on a go-forward basis. In addition to that, almost 70% of our seniors, and I would put that this is the rising risk right now that we talk about, all have 2 or more chronic conditions. When I was in BC, I worked there as a strategic planner, and we actually found that most people had 5 or more chronic conditions. So it's not just that you've got COPD or you've got CHF or you've got diabetes. You probably have many of the risk factors associated with it, and we knew that going in. The other thing is that 5% of our Ontarians account for 66% of the healthcare expenditures. We know that, and we are feeling the pinch because most of the time we will see system failures, not people failures, and I want to be clear about that. System failures where people are not getting treated for their chronicity out in the community or appropriately. They get sick, they flip in the hospital, and we get a vicious cycle where we start to get readmission rates. So we start to see that a lot. So the high costs are not actually due to patient acuity in many cases. We can treat people with the Da Vinci robots, which we have and we use. They're great in and out. It's the people that are dealing with the frail, the complex, and the chronic illnesses that are really now putting the burden on the hospital system and will continue to do so. So we said that we had to do something different and that we were going to look at a new approach for healthcare. As a hospital, we couldn't do it, and we knew that we needed to partner with our community providers, we needed to partner with industry, and we needed to find the right technology to enable us to do what we wanted to do. So the first thing that I want to say is this was not a technology solution, and I want to be clear about that. The technology allowed us to do what we needed to do differently for our patients, to ensure patients got proactive versus reactive care, to ensure that they were looked at the home, to ensure that we got them out of the hospital as quickly as possible with wraparound services, and that the transitions out in the community were consistent, and that it was collaborative care. And then finally what we wanted to do, and it was going to be a bonus if we got there, but this was not the driver, but I'm an administrator, I'm the chief operating officer, so I put on my administrative hat. I also wanted to reduce costs because we are, pardon me, we're steward of health pay of taxpayers' dollars. So that ultimately, but that was not the reason why we did that. So how did we go about doing it? Well, we had a vision. We knew we wanted integrated teams across the environment. So in Ontario, we're not regions like you would see out west or in some states. We have separate arms. So CCAC was a different governance and a different structure than what the acute care hospital was. But we knew that patients don't care who's providing their job. They don't care who the board is. They don't care that I report to a hospital and somebody else reports to the CCAC. What patients care about is that they're getting the best care and they're getting timely care and that they know who their providers are and that they're getting safe care. That's what we heard from our patients. So we knew that we wanted a wraparound team that went across all of the service providers. We knew that we wanted an integrated care pathway where standards of care were provided and it was the same standards whether it was in the community or whether it was in the acute care or whether it was from one of our partners. We wanted to make sure that there was that consistency and standardization and that they were evidence-based practice. We wanted to make sure that we provided the right education and that we focused on self-management and the management of comorbidities and chronicity. And we also wanted to make sure that we used physicians consistently, but that we had the technology to enable us to pull that all together, because patients were going to be at home, and we wanted to know that they were being looked after appropriately. So it was a technology piece for that. And then we were going to also partner with some of our community ambulatory care clinics to ensure that there was follow-up should it be required. So that was the vision. It was not easy. The first thing I'll tell you is we had to break down significant roadblocks, and the biggest one was how to get everybody to partner and take off their corporate hats. And that was the first thing we did. So we got together and we said, well, how are we going to do this? And as a group, we got all the partners in the room and we made some principles and said, we are here for patients. This is a patient experience model. This is not about Donna at CCAC, or it was not about me at the acute care. It was all about what are we doing for the patient. So from now on, whenever we talk about somebody, let's talk about them in the first name. And we actually named the patient Norman. So you're going to see a little bit about how we got to Norman. But we named him, and that, surprisingly, that was probably one of the most brilliant things that we did. Because now I'm not going, oh, well, acute care is not happy with that. Or Donna's not saying, no, we can't afford to do that because it's CCAC. We said, what would Norman want? What does Norman need? And when you personalize it to a patient, it makes such a difference in the planning. And eventually we forgot who we represented at the table other than that patient. The second thing that we did is we knew we had to create a common care pathway, and we didn't want, and I knew we were doing this wrong, by the way. In order to get providers to stop thinking like providers and put themselves in the patient experience, I thought we needed to do a process map. So we actually process mapped the patient journey from primary care with COPD. So we picked one common illness, first of all. We picked COPD, which was also wrong. It should have been comorbidities in the most ideal world, but we knew we had to start somewhere. So we picked COPD, and we said, let's map this from primary care all the way through the hospital system. You're going to kill our patients. It's not safe. I mean, we heard every single thing in the book, and we said, absolutely wrong. We think we've got a solution here. We will provide Uber services. So we actually said, we're going to provide more services than those patients would get in the hospital and the community for the first number of patients, just to make sure that they're going to be looked after well. And by the way, there's a dashboard that you're going to be able to check in on your patients every single day that you want, and that we will be able to provide better care out in the community than you're actually getting in the hospital. So lesson number 2, always find that one person who's willing to try something. Because we had about 4 respirologists that said no. Some of them actually even said a little harsher than that. And we had one that said, you know, okay, I'm game, let's try it. And he worked with us really closely. And what I found working in healthcare is once people will sit and watch to see where it goes, because we're fairly conservative. Once they saw it start to go, we got more and more people engaged. And actually then at once upon a time we had standing room only for the steering committees, which was great. That never happens in healthcare. So we reduced it to a length of stay of 5 days. Then we sent people home and we set them up with the technology to do monitoring. It's the eShift. So we had a nurse that looked after 4 patients electronically and did the monitoring. It was great. It was like a hospital in the home. And it made such a difference for all our sanity to know that there was somebody there 24/7 keeping an eye on the patient. But what we also did is we knew that somebody needed to be the eyes and the ears and the hands-on the units. So depending on the needs of the patient, with our home care partners, we sent out a team that were able to look after the patients. So that included our therapists, we partnered with ProRest. They supported us with oxygen needs. We partnered with VON, who provided the nursing support, and it was a consistent team, which was incredibly, incredibly important. And I think that was one of the best things that we did, is we partnered with one provider who had a single source team. So we trained them, patients got to know them, they were educated, instead of a different person coming every day. So we kept those patients there, and we kept them up to 60 days with those wraparound services. If they needed it, we could do it a little bit longer, but most people actually, we didn't need it. And then they moved into self-managed support in what we called eShift, where they were still monitored. The other thing we did is we had 24/7 support, where patients could call if they ran into problems. That was a second thing that I think was foundational, was the ability for the team to monitor, see if a patient's getting in trouble, or if the patient felt they would call the 24/7 nurse, and we were able a lot of times to calm them down. People, when they're in COPD and exasperation, start to panic, and we were able to bring that down so that they could manage through that. So that was the model. This is how eShift worked, and what the brilliance of it was, is it allowed everybody access, including the family, should they want it, into the services. So I, as a provider, could go in and look and monitor my patients, the family could, they could do it, the directing nurse was there, and we had the EMR, and it was real time. And I think that's what engaged the practitioners the most, is that it was real time, and you were getting data real time. So you're not waiting for hours or months or weeks, but it was a model that created the confidence that I can deal with this remotely and the technology is available. So this is what it looked like. It was on demand. It gave trends and predictive planning, so we could actually start to plan. And one of the things that we found is that we had over-serviced patients in the home. In fact, they said, don't send this to anybody, we don't need it, we're comfortable with this. We know that there's somebody on the monitor that we've got it. Even things like we provided them iPads, and they said they didn't want them, which I thought was amazing. I would have wanted one if it were me, but anyhow, they didn't. As we started to move through this, we found that we could really tighten up the model from both a cost and provider. So this is a team. Really, it was about collaboration. If I had to say anything, it was about integration and collaboration of a full on-board team. So on the inpatient side, we put a navigator in. They started discharge planning the second the patient entered the hospital. They got put on the care pathway. In the home care team, they had the technician, physiotherapist, occupational therapist, and then we had a bridging team that went in between the acute care and the community side of the house. And I think this was a big difference. It truly was a team. It was not a group of providers just working together. It was a team who was dedicated to what they really focused on. And here were our biggest community partners. It was the CCAC, now the Southwest LHIN, St. Joseph's, VON, our family health teams, our primary care. That was one of the biggest risks and problems that we had. We had a really hard time getting primary care engaged. The reason why I found it was with complex patients, primary care actually didn't have the confidence in many ways to deal with these types of patients. When they found that they had access to eShift and the monitoring, they started to gain the confidence, and now word is spreading, and we're starting to get a lot of engagement with primary care. The benefits, I'll show you some data around this. We did have a decrease in length of stay significantly. When I got the first results back, I thought, okay, is this our decision support team plan around here? Like, what's going on? The results were significant. And my question is it sustainable now? Was this a blip? Was this a 1 month? Is it a group? Is it sustainable? The answer is yes. It was dedicated care providers through the patient journey, which gave consistency in care, and it allowed the patients to truly get to know the providers. The second part was we engaged families, and that was a huge lesson for us. Families probably know more about the patient than anybody. And we learned by having a consistent team, we had to listen to what the family said as well. Consistent delivery of education and support. So patients were no longer going to Dr. Google. They were going to the team to start to get information. We did find improved support and access to an RN, and the patient experience was significantly better. So you're going to hear from Doug if you want to ask him questions, I'm sure he'll be happy to tell you. I'm going to tell you a little bit about Hugh. So this is Hugh. This is a real patient. He was a patient at our hospital. He was one of the first to go through the program. So Hugh had been a heavy smoker, and he had been housebound for about 5 years. Had never been able to go out of his house because of all of the symptoms and whatnot. So since he got on the program, he's been smoke-free now since 2015. He's absolutely got off it. His respiratory indicators have improved significantly. He's been exacerbation-free since 2015. He has been not a regular person going to our ED visits, which he was. And for the first time ever, he's in many, many, many years, he's leaving the house to go visit his sister. This, to me, is what this is all about. We can talk about technology and about teams. At the end of the day, it's what difference are we making to patients so that they can live their lives in a much better way than they can. The brilliance about Hugh is he's actually self-managing now. He knows how to look after his COPD. This just shows you from, for the clinicians in the room, it has made a difference in respiratory rates. The top line is what our target was, and since the start of the program, we've consistently exceeded respiratory rates. And this is, for the administrators in the room, this is where it truly made a difference. So our length of stay went from about 8 days, we're down to 3.7. So every time we make a change, we create a new Norman. So I think we're on about Norman 3.5 now. So Norman's COPD again. Norman is down to 3.7 days. So we've gone from 11-day length of stay down to 3.5. And patients are doing better. They're getting much better care at home. Our 30-day readmit rate has gone from 25% with the 217 patients. So it wasn't all hospital, it was the 217 patients that we put through. So 30-day readmit rate's gone from 25% to 12%, and that's been sustained and continues to drop. Our emergency department visits have dropped almost 100%. So we've had, this was for all causes, emergency departments, that's how we capture it. So there's a couple of people in there that broke their hip. So, but they're included in that because it's all cause. So it's actually better. We've almost eliminated emergency department visits for this population, our target population here, and it was because of the 24/7 line is what we're finding. And then the hospital cost, the cost per patient for these patients was $10,000. For the hospital, it's been brought down to $4,000. And then our CCAC costs are down to, they went from 3 to 2. So our total costs have been reduced so far by 42%. It's actually gone down further again. So this has been, we started this 3 years ago, and it continues to improve. So it has been a sustainable model for COPD. My question is it sustainable for anything else? Because in the real world, what we should be looking at is comorbidities, not at just single disease. So I thought, okay, the next one I'm going to try before we get to a full comorbid patient, which is where I think this needs to go, is we decided to spread it to CHF. And we did the exact same process. Got teams in a room. We started doing the process mapping. It was directed by patients, and the patient is now female. We wanted to be gender neutral or gender fair. It's Ruby. So Ruby is our CHF patient. We're now on about Ruby 3.2. And again, experience-focused, integrated team, care pathways across expansion of eShift. So we continue to utilize eShift because we feel that is probably one of the largest enablers that we have to support us, and it was to sustain and test the model. We ran into some bumps, and the respirologists were hard. I will tell you, the cardiologists are harder. They were bound and determined they were not going to reduce the length of stay because, again, it was almost the same story that we're hearing. It's not safe, you don't understand, Laurie, we're an academic health science center, our patients are more difficult, they're more acute, like we're hearing it all. And it's been a little more challenging to get them to understand that it's safe. So we're starting slowly, but we are making some inroads. So our hospital length of stay is going down slightly. Our 60-day readmission rate, so this is what we really decided to focus on, was our readmission rate for CHF. That has come down, and it is coming down significantly. Our CTAS emergency visit, this one, 105%, it was because it was an N of 1. This was an individual who did have a really severe flare-up of their failure and ended up in the hospital significantly ill. So not like COPD, they did come back very ill. But we have been able to reduce it downwards in some of our others. Our hospital costs are starting to decline. Our CCAC costs are definitely declining. So as we start to bring patients through, my belief is starting to become a sustainable model. So it is transferable. I think this model is a foundation for the new healthcare system, in my opinion. I think as we start to see more and more patients growing and aging, and the volumes getting larger and larger, if we don't do something different, the healthcare system is not sustainable. And I would suggest that this model is one that could be leveraged anywhere in order to help us shift out of the acute care into the community and give better care that's better for patients, it's better for providers, our staff experience has gone up, and that we can leverage some of the new technology. So here's a summary, just how many patients we put through. I'm not going to dwell on that, help you. Some of the risks, the number of patients, there's way more patients we could put through with this than we actually are. There's no primary care coverage. We've had to work through that. We had to work through funding for specialists. We didn't have a funding methodology for specialists to do it on the phone. We had to get creative in that. And then again, comorbidities. So the next expansion is we're continuing to expand it out. I would like to see this move into the mental health population. I think that's a good one for us to move it forward. I talked to Donna today about stroke. I think stroke is another one that this would work very well, and eventually get to full-on comorbidities. So demonstration project. In our hospital, it's not a project. It is becoming real. It's how we're looking at providing services. And I think we just need to ensure and prove to government that it's cost effective in order to get the funding for a different model. So happy to answer any questions, any of my colleagues here.
From a community perspective, how did the nurse-patient ratio align with what previously the LHIN or CCAC used to have, so for sustainability purposes?
So for in the community, we have a care coordination model that you're probably familiar with. What we did, we changed it a bit, and we created the care coordination was actually doing hands-on nursing as well. So she would have been the care coordinator in the hospital that saw them, and then she saw them within 24 hours out in the community and followed them through. And then they had the technicians in the home, as well as VON would have had their nurses in the home. So I'll let David talk a little bit more about VON.
So what we've learned over the 3 years that we've been doing this, and it helps inform as we expand the same model of care into other patient populations like stroke and orthopedics, is that as the population grows and as the clinicians became more expert, the number of patients they're able to manage and oversee quite safely and quite effectively grows, but not linearly. So when you add 20 patients from 4, you don't need 5 times as many clinicians supporting the patients, you need 2 times as many patients. So it becomes a much more efficient and effective model of care because of all of this transfer and sharing of information and the fact that we're all working from one template.
And I would say our care coordination model for the community with the clinical care coordinator, because the patients are at varying stages during the process, they can carry a caseload of up to about 50 patients.
Yeah.
So maybe Doug could share how that impacted him as a patient.
Well, definitely made life a lot easier, that's for sure. I guess the biggest thing was it kept me out of the hospital because there was You know, the first month you had a lot of people coming to the house all at once, and it was really overwhelming at first, but then it was actually quite comforting. But then I had a couple of other flare-ups after, but they were dealt with out of the hospital. My respirologist was on board, so I had everything within, there was one shot, within 15 minutes of my phone call, I had the prescription ready at Shoppers. So it was that quick that all this stuff worked. So it does make a big difference. And like I was saying to you earlier, it would be a lot better if the family doctors were a lot more on board. That's, you know, straight up, it's true. You gotta get them on board. Specialists are on board.
Well, and I was saying to Doug earlier, when you asked about the patient experience, I was able to go out and do a home visit into a patient's home. And this was a gentleman that had COPD. And what he said the biggest difference for him was often he wouldn't go to a specialist appointment. It took him too much energy for him to walk from here over to that chair. So he said, I just wouldn't bother going. But with this program, he was able to sit in his own living room with the iPad there. He was able to connect up, see the specialist. So he was being monitored, and he didn't have to exert all that energy to go out. So he said it made a huge difference for him to be able to do that from the comfort of his home. But I do agree, primary care is a bit of a challenge because primary care still often wants, as Doug and I were chatting, they want to say, no, just go back to the specialist. Just let them handle your care. But truly, with this level of support, the primary care team can manage these patients, but I would say that's still a frontier that we quite haven't got captured yet.
Yeah, there's a bit of, my experience is there's a bit of a fear factor in there, and that I understand that when you're seeing a lot of patients and there's somebody out there. So to me, it's how do we get the message out that it's okay. You primary care physician are going to be supported, your patient's going to be supported, and yet you still are going to be able to be the MRP of it. So there's a whole education piece that we still have to do. But it's growing. We're starting to get more and more as people start to see that this is a really solid program. Mary, could you?
Just a quick stretch question. As you look at this, and we heard from Deloitte how patient empowerment is so important, would there be an opportunity over time to have that health professional and the arms, the outreach, be the patient themselves empowered to manage their own care?
Oh yeah. Like particularly with chronicity, self-management is a big piece. So not just the traditional, I know how to do it, but it's when I was in BC, it was called partner patient as a partner, where patients actually direct their own care and are actually one of the partners. You're one of you're one of the care team. Is you are, and in fact, once upon a time, we actually said patients are the true primary care providers because they are the ones who knows what's going on and what they need and what they want to work on. So I would support that. I think it's going to take a long time to get that mindset changed.
Or the patient is going to change our minds for us because, you know, people like Doug, as time goes along, have more say in what they want to do.
Yeah, we're starting to find that consumers have, I don't know about you, but we're finding that consumers are much more knowledgeable and are much more demanding about what their expectations are. And I think as being in the service industry is what I call ourselves, we need to serve our patients. And how do we do that in a way that's still going to help them and optimize their health as much as possible? Any other questions for, yeah, go ahead.
Sorry, I know I'm asking a second one. What about the flow of the information back to, so as an example, when a patient returns back to the emergency department at 8 o'clock in the evening, let's say, that one platform that exists when they're out in the community, how much accessibility to that information is there for, let's say, the emergency physician anymore?
Yeah. So there's a couple things. So we are on an electronic medical record called Cerner in our hospitals. So we've been able to flag who's on the model. So anytime anybody comes in and they're part of Connecting Care to Home, that's what CC2H stands for, is we flag it and that generates a whole process. In Southwestern Ontario, we also have something called ClinConnect, which allows, it's almost like a platform, it's a Heil almost, where it allows you to go in if you're a registered user, and that you can pull data from all the different sources. So that's what we do in the emergency department. So we've leveraged our EMR in order to do that. But it's really important. It's that transition of care back and forth in the team that I think is key. And the standardization, that's why if you could whittle down to standard care as much as possible, the better it is. Yeah. Any other questions? Great. All right, well, oh yeah, sure.
You mentioned that there's way more patients able to participate in this program than can. What are some of the barriers holding back?
Sorry, what are some of the barriers in?
Holding it back from expanding to what number of patients?
Right now it's money. Obviously, this we are funded through the government, for those of you that aren't from here. And we're using our base funding because we can't use some of our other funding sources. So to put in a navigator and the wraparound services and whatnot, we actually had to find the funding for it. We were fortunate in that we had a very willing partner. And in fact, at one point, we were going to do a cost sharing. So CCAC was paying for some, we were paying for some. And we were at one point actually starting to think about getting some sort of a venture going where we would pool our money. And then if we made a profit, we would reinvest it back into the program. And if we took a loss, we would each take the risk of the loss. But we both saved so much money that we didn't need to worry about it. Yeah, but it's all about funding. I would do this as far and as wide as I could if I had the money that I could start to convert. But you almost have to run two systems at the same time.
Seeing as it pays for itself and the healthcare, the provincial government is funding the healthcare, are they seeing this advantage and looking at it change?
They are. What we did, we had started actually this government's done some pilot projects called the Integrated Bundled Funding Model. And we were one of them, and we decided to do it opposite what everybody else did actually. And so we've been uber evaluated. The Connected Care to Home has been really evaluated, and it's just statistically significant. Like, we're the one project that's actually been able to get success and outcomes and maintain it. So it has got the government's attention. I would suggest, though, that things don't move fast in healthcare in government world. So I think it'll be a while before it starts to expand. But people have noticed for sure. Yeah. It all comes down to money, doesn't it? Like, yeah, at the end of the day. But it's really, truly all about patients. And I just want to, once again, thank Doug. He has been great to come and share and talk about it. It's a hard thing to do when you're a patient, but to me, this is what it's all about, is to try to make Doug's life so much better. So just wanted to say a special thank you.